So our next speaker is Dr. Bai from the Johns Hopkins Carey School of Business School and Bloomberg School of Public Health. Dr. Bai is a professor of accounting at the Johns Hopkins Carey Business School, a professor of health policy and management at the Bloomberg School of Public Health. She's an expert on healthcare accounting, finance, and policy, and was a visiting scholar at the Congressional Budget Office from 2022 to 2023. Welcome, Dr. Bai, and we look forward to your talk.
Thank you so much, Dr. Mohan. What an honor for me to have this opportunity to present. Thank you. So I'm going to share my slides. I'm going to talk about three things about the hospital finance. Because I'm an accountant, I teach accounting, healthcare monetary issues are really interesting to me. And my job here is to give a overview on the three issues for hospital finance. Number one, hospital profit. Number two, hospital price transparency. Number three, charity care. And then this afternoon, I believe 12:45, what my co-author, Dr. Li, is going to present our co-authored work on the kidney care, and we just published. So let me share my slides. So let's first think about the hospital care among U.S. healthcare spending. I think we are probably very familiar with a chart like this. So among the total healthcare expenditure in the United States, the largest component is hospital care. Then let's look at the price trend. From 2000 to 2020, if we look at all the consumer products and services, and then we can see that hospital services is the one with the highest, the single highest. You can see it's really, putting all the other services a much lower range. Hospital services is having the highest growth rate from 2000 to 2020. And then we might want to ask why, but we can discuss later. But this just, I want to use this to open our today's talk. So hospital spending is the highest among all healthcare service category, and hospital prices have been really increasing as compared to other services. So if you are an executive at a large hospital, you probably face some kind of compensation contract, right? Some incentive structure. So you imagine what kind of incentive structure would the board give to you if you're working for a nonprofit hospital? Do you think the hospital board would say, oh, please focus on charity care, please focus on price transparency? That would be the priority. Probably not, right? Yes, so today's world, nonprofit hospitals, for-profit hospitals are very similar in terms of pursuing profit. In other words, the line separating nonprofit and for-profit hospitals are becoming murkier and murkier. So you are just facing this very simple equation. As on the slide, you are focusing on profit. So the profit is the difference between revenue and expense, right? Revenue minus expense, profit. If I want to, as a CEO of a hospital, if I want to increase my profit, I can do two things, right? Number one, I must increase my revenue. Number two, I must reduce my expense. This will always hold, right? In any circumstances, you want to do the two things. Now, how do I increase revenue? Well, our revenue, hospital revenue, comes from two channels, right? The number one is from commercial. Number two is from government programs. So this kind of dynamic, revenue minus expense equals profit, and the CEOs are motivated to focus on profit, explains almost all hospital behavior, right? So they're going to enhance revenue from commercial payers through what? Through market power. So we're seeing consolidation both horizontally, buying small hospitals, as well as vertically, buying physician services, so they can control all the referral within the network and increase the market power, right? So that's the first point. Enhance revenue from commercial payers through market power. Then we also have to focus on revenue from government programs, right? Medicare, Medicaid. So what do? They will have influence policymakers to get a higher revenue from these programs, because these programs are determined, right? The payment, the grant, appropriations are determined by government. So they have to find a way to influence the process so that they can have a higher revenue from these programs. For example, 340B program, right? Or site-based payment. Like if you receive care from hospital, you get you have to pay more than if you receive care from a physician office, even if the same care. That's a second approach. The third approach would be contain expenses. So let's say I'm going to limit my charity care because as long as I don't need to do more, I'm going to do just enough for the charity care. And then I might increase the utilization of nurse practitioner, physician assistant, etc., to contain my expenses. So it is through the three channels hospitals improve their profit. So let's just quickly look the Medicare. So for Medicare, as you can see, Medicare payment scheme has become so convoluted. It's almost impossible for an independent practice. Let's say you and I, several of us want to start a hospital. It's going to be very difficult just to deal with this compliance. Okay, and then we'll know, the Medicare payment for most services is not very it's not very high. So many hospitals have concluded that they are not going to make money from Medicare. However, that's a thing for discussion. But I just want to lay out that Medicare pricing is lower compared to commercial, and also it is subject to a regulatory process. And the second revenue channel would be Medicaid. So Medicaid, traditionally Medicaid pay very little, right? Both managed care and fee-for-service. It's much lower even than Medicare. But now because of the provider tax, which is being debated right now in Congress for the big beautiful bill. So if there's no change, then in some Medicaid expansion states, hospitals are paid at a average commercial rate for their Medicaid services. So that's very lucrative for hospitals. But if this bill passes, it's going to be Medicare rate. But in general, Medicaid you already pay very, very low compared to even Medicare. And then commercial. For commercial payers, this is the most recent RAND report showing that both inpatient and outpatient commercial prices, it's the inpatient, outpatient, and commercial prices, and overall, this red line is the overall commercial prices for hospital services are about almost 2.5 times of Medicare rate. So this is Medicare rate. Okay, so it's keep increasing. So we are seeing commercial payers are subsidizing hospitals in terms of I can use subsidy. People say cost shifting, but anyway, hospitals are getting much more from commercial payers to somehow fill their deficit from delivering service to Medicare and Medicaid, at least from the financial perspective. Then this is our study published in 2018. Still today, the conclusion still holds true, meaning that even for commercial payers, different payers pay different price depending on your negotiation power, right? So you look at the solid line. The solid lines are small insurers. Small insurers, they are dealing with for-profit hospital, non-profit hospital. You can see the prices they pay is higher than HMO, PPO plans. Why? Because small insurers have a smaller negotiating power, so they're getting a higher payment. So all of this results are before the price transparency rule came into effect. So price transparency rule came into effect during the Trump 1.0 in January 2021. So it requires hospitals to disclose two things. So machine readable file for all their every service, and then for consumer friendly, for shopball services, 300 shopball services, you must display in a consumer friendly way. But overall, it is trying to use price transparency mandate to force a price competition on the hospital market. So we use the data, did a lot of study. But before we dive into what's the information disclosed by price transparency, I want to just mention this dynamic. Like, why do we need to force hospitals to disclose price? In fact, if we look at any cash pay, there's no insurance. Our providers directly dealing with patients paying cash. In this kind of markets, we do not need government to be there saying, you guys have to disclose price. There's no such a need because all providers voluntarily disclose price in the most consumer-friendly way. So for example, think about plastic surgery, right? Or over-the-counter drugs. Or in this case, in our study, we look at the ambulatory surgery centers only focusing on cash pay patients. For this kind of markets, the providers voluntarily disclose price. So that tells us the root cause for the lack of price transparency is not superficial. It's not saying, okay, these hospitals are just bad. They don't want to disclose price, but it's because we have a third-party payment system. The patients are kind of insulated, right? So there's no benefit for the hospitals to disclose. That's why they don't. Okay, so that's just a more philosophical discussion on why this price disclosure mandate is needed in healthcare, why it's not voluntary. Okay, so this is our earliest study, 2021, immediately after the rule came out, the first batch of information there, then we did the study looking at the colonoscopy. This is using all the disclosing data points at that time. So we're seeing a very large variation in colonoscopy commercial price. By the way, this is all commercial price, not Medicare, Medicaid. There's no need, right, for the Medicare, Medicaid price to be disclosed. These are government set the price. Now, look at here, we have providers, hospitals having around $500 for colonoscopy. And then we have providers have $8,000 colonoscopy. And these are original, these are negotiated prices. It's not a charge, it's the actual prices paid by commercial payers. Then we look at the surgery services. There are 22 CMS-defined shoppable surgery services. So we look at 22. These are just a snapshot. We have more in the paper. This one done by my with Martin Carey, who's the FDA commissioner currently, and with another co-author. So you can see here we have a pretty large. If you look at P10, P90. We have pretty large price variation. Again, these are commercial negotiated price for the same service, very large variation, can be 10 times. And then we look at the radiology services. So there are 13 shoppable radiology services designated by CMS. Again, this paper is with Martin McCurry as well. And then we found, again, very similar results. There are huge variation, right? Almost 10 times. For the same service, you have $1 price and I have $10 price. So that tells us the market is really not competitive. Next one, we look at the within hospital insurance company payer variation. So what do I mean? So if I am a hospital, I am dealing with Blue Cross Blue Shield. Guess what? Blue Cross Blue Shield administers several plans, right? Not just one plan. There are going to be different plans within this pair, within the group of plans administered by Blue Cross Blue Shield, negotiated with me, the one hospital for the same service, we are seeing large price variation. You can see here. So this is P1, P10, P2, P90. So for about 10% of hospitals, for at least for the first service, brain CT scan, within the same hospital insurance company pair, we are seeing more than 6 times price difference. So that really raises the question whether insurance companies are doing the best job to help plan sponsors save money. But obviously, they're not giving the best deal to everybody. So, you know, I always say insurance companies have their own incentives, not necessarily aligned with plan sponsors, right? So this is a great example. And then we move on to cash price. So cash price is also a component required to be disclosed in the price transparency rule. So if you are not uninsured, or if you are insured but you have a high deductible plan, you might have incentive to pay cash price if the cash price is cheaper than your cost sharing, right? So we look at the 70, in total, there are 70 shoppable services designated by CMS. And we found, so if you look at the percentage in percentile. So if you look at percentile, it's around 50%, right? So about half of the occasions, the cash price is lower than the median negotiated price in the same hospital. So in other words, about half of the negotiated price is higher than the cash price. And then there are about 15%, 10 to 15 to 20% of hospitals set their cash price lower than even the lowest commercial price. So that tells us they unilaterally determine the cash price from the market. This is purely free market, right? There's no middleman, and determined by hospital. Although it's such a small market, is already competitive as compared to mutually negotiated insurance price. And then we did and we did another study in health affairs. We found a similar result, that we used a more complicated design, research design. We found a similar price. So I did not put it here. And then again, using the price transparency data, we're able to find, we will have this unprecedented insights into the price comparison between physician in the hospital and non-physician in the hospital. So we look at the physician in the hospital and then the competitors, both nonprofit and for-profit hospitals in the same county. So they're really competing among themselves. But then guess what? The price differential, look at it here. The price differentials are significant, meaning that the physician in the hospitals are cheaper in terms of their commercial negotiated price than their competing peers. And we also found in the study, I did not put in the slides, physicians in the hospitals also have a higher profit margin. So they have lower price, they have a higher profit margin, and from the prior literature, we know physicians in the hospitals also have better quality of care. So this is very, to me, very strong evidence, and especially given that the Affordable Care Act bans the expansion, the establishment of physicians in the hospital. So I hope this will provide an important evidence against the arguments that physicians should not own hospitals. We also look at hospital versus ambulatory surgical center. There are many surgical services can be delivered in both the outpatient setting in hospitals as well as an ambulatory surgical center setting, right? So we look at the facility fee, not physician fee, just the facility fee. We found nationwide for 3 types of colonoscopy, AIC is much cheaper than hospital. So it's about 50% more expensive for hospital delivery than AIC delivery. Again, all of this would not be possible if we did not have we had not have the price transparency information. Okay. Sorry, this is the paper I just mentioned, published in Health Affairs about cash pay. We got the same results. All right, so let me just quickly summarize so far. So I think my biggest messages so far is 2 things. Number one, what is the objective function for hospitals, nonprofit and for-profit alike, right? To increase profit. So how do they do that? Increase revenue and control spending. And then we, from price transparency, we got a lot of insights. But most importantly would be the insurance companies are leaving money on the table. Why? Because not because they don't want to do a good job or they cannot do a good job. It's because of misaligned incentives. In many cases, insurance companies do benefit from higher prices, not lower prices, especially when the clients are captured. And also we found cash price are competitive in many situations. Great, now let's move on to the last topic for my talk, that is charity care. So charity care, I want to link back to my first slide. So if I'm a hospital CEO, if I want to increase my profit, I have to contain my spending, right? Control my spending. And the charity care to me is a spending item. Every $1 I save, from charity care is $1 more for my profit. That is the mindset. I don't want to put some moral projections on CEOs. CEOs are like everybody else in healthcare. They're trying to taking this as a business, right? If the incentive structures force them to focus on expanding the budget, increasing profit, of course they would not really focus on charity care, taking that as just as a simple expense item. So this is our study published in Health Affairs. We look at non-profit hospital and for-profit hospitals, and as well as government hospitals, and look at their spending on spending on charity care. And we found that in aggregate, nationwide, nonprofit hospitals spend about $2.80 for every $100 expenses. Let me repeat, for every $100 expenses incurred by nonprofit hospitals, they spend about $2.80 on charity care. And this number is lower than the $3, I believe $3.20 of for-profit hospitals. So in nationwide, they're spending less on charity care compared to for-profit counterparts for relative to the total expense. Then as I show on the slides, we also did a rigorous design that is only looking at markets where we have all three types of ownership. So we have nonprofit, for-profit, and governmental hospitals. And we found, look at here, the for-profit hospitals are this 12% of the markets. The for-profit hospitals are providing more than nonprofit hospitals, right? So, and then you can see here about 19%, adding two pies together, and then with two slices together, we can see the for-profit hospitals actually are providing more charity care than both government hospitals and nonprofit hospitals. Then the question is, what's the conclusion? Remember, right now, there is no quantitative requirement from the federal level on how much charity care hospitals must provide. The only requirement is from the ACA saying hospitals must have a charity care policy in place. Nonprofit hospitals must have a charity care policy in place. So for me, the best research design I can have would be compare nonprofit versus for-profit hospitals, because for-profit hospitals do pay tax, right? And nonprofit hospitals exempted from income tax, state sales tax, property tax, and when they issue bonds, they can get a low cost of borrowing, and they receive tax deductible contributions.
Why we're here, and that's because several sources, including the health services and resources.
So the nonprofit hospitals do get a lot of tax benefit from taxpayers, right, or subsidies from taxpayers. So the question taxpayers should ask is, are we getting a good deal, right? We give you all the subsidies. Did you give us enough in return? Because that's the question we ask in this NEJM article. Do nonprofit hospitals deserve their tax exemption? And our answer is, if you compare to for-profit, which already pay tax, also providing employment, etc., they're not doing enough. So this is an ongoing discussion, but to us, disclosure would be the first step. Let's see how much tax benefit they get, how much they deliver to the taxpayers. So this is all the three things I want to mention today. But we have to look at charity care within this profit-driven, budget maximizing framework to understand hospital behavior. All the there are many individual events, but if we put the individual events all under this framework, right? Don't think hospitals now are more like a charity, like a church, but we should think hospital more like a business. Then many behaviors would be understandable. So let me stop here.
Thanks so much for that really fantastic talk. Very thought-provoking. If possible, can you kind of expand a little bit more on what you think might happen if we see a lot of this push of patients off of Medicaid with spending kind of proposals that will cut Medicaid eligibility and enrollment and onto charity care? How might you expect that to impact kind of what care hospitals willing to provide?
Thank you, Dr. Zhang. This actually, I agree with many commentators. If you stand from hospital perspective, this is pretty scary. Think about hospital perspective. Hospitals have been very active in pushing ACA. Why is that? Because ACA expanded Medicaid, so hospital would face lower bad debt. In other words, more people being covered, they're gonna pay, right? They're not gonna just refuse to pay. So that's good for hospital. But now, if you are seeing more people off Medicaid, the concern would be, am I getting more bad debt? In other words, do I collect the revenue as effectively as before? So that's the main concern. However, I would say my understanding is there's a lot of crowd out, right? So the people who off Medicaid, they're gonna join commercial insurance. So if that happens, then I think hospitals worry probably is overblown. Yeah. But also, in several more studies, not putting the slides, I do believe right now we have a huge problem for low-income patients. This kind of arrangement, Medicaid arrangement, we spend a lot of money, taxpayers. However, the patients are confined in a very narrow network. Why don't let them get some control of their money? So let's say I'm Medicaid patients, I pay the same price as a commercial payer, I can see a great doctor, right? There's no more constraints. So I think that's something we should consider. Subsidize the patients, not subsidizing the system.
Thanks. So we have a question in the chat about kind of why there's been an increase in consolidation lately when kind of the benefits financially of consolidation for hospitals has been kind of true for a very long time. Do you have a sense of why this is suddenly increasing more and more over the last decade or so?
Yeah, the soil for independent practice or small practice has been made very toxic. By what? Not by greed. I do not believe it's greed, but I believe it's by bad policies. So give you two examples. One, as we have so many regulations, can you imagine small players to survive? Layer and layer regulation requires very complicated process, compliance office, etc. That's why PE firm can do this, right? PE can consolidate the compliance part and then get a small ones under their wing. And then think about 340B, the Stark law, by the way, certificate of needs law, and ban on physician in the hospital, etc. All these regulations are very friendly to incumbents and very unfriendly to independent, smaller players. Therefore, the playing field is uneven. That's why physicians have to be consolidated. Like if physicians are so happy, making so much money, and life's easy, why would they willing to give up their autonomy? Nobody will, right? So I think we have to look at the root cause why our soil has been spoiled, has been so toxic. Yeah, and that's why I always think about policy roots is policy failure, not necessarily market failure.
Thanks. And I'm going to go over time just by 1 minute since multiple people have asked the same question. But you mentioned that insurance companies might still benefit from higher prices in some cases. Can you elaborate more on why that might be the case and when?
Yeah, great. So if it's a very competitive market, let's say I'm Johns Hopkins, I hire you to run my benefit. If I can kick you out, like every year I choose, right? Then you dare not to give me high price. But the reality is not like that. In the employer insurance market, insurance companies are highly the employers or plan sponsors are highly captured. We don't see movement, like there's very little turnover. So the clients are largely captured. Once the client are not leaving me, if I'm an insurance company, guess what? My revenue is linked to medical spending. If next year my client medical spending drops, my revenue will drop as well. So I would not want to see my revenue drop, right? So lower spending in terms of lower utilization or lower price will go against my revenue. So again, if it's competitive, there's no such a problem. But the market is not very competitive, so the insurance company do get a cut from higher spending, especially because of medical loss ratio. That's a part of ACA rule. Sorry about that. That's going over a minute. Sorry about that.
No. Thank you so much. That was a really, really
Thank
fantastic
you.
talk. I feel like I learned so much in those
Thank
30
you
minutes.
so much for having
Really
me.
appreciate it.